Coming to the statistics, what is the burden of this childhood cancer presently? Whenever you see a patient of cancer, load of cancer, it forms about 5% of all the load that is presently there. Childhood cancer forms about 5% of the total cancer load. When coming to the particular numbers, it's about 4 lakh children are diagnosed every year globally. And when it comes to India, it's approximately around 50,000 to 70,000 children are diagnosed with cancer every year. 50,000 to 70,000 new children are diagnosed with cancer every year. Coming to the survival statistics, are we going to cure these children or how are they going to do? This is the thing that will explain you in a proper way. So, about 80% of the children with cancer will survive in high-income countries. But when it comes to, in stark contrast to this, only about 20% of the children with childhood cancer survive when they are in low and middle income countries. In high income countries, if 5 children are diagnosed with cancer, 4 children live. They survive the cancer for 5 years. And 1 child with the problems which will make the child die. But what happens, the same scenario in low and middle income countries where we are living in, for 5 children, 4 children die, right? So this is what it explains. So what are the reasons for that? It's really very bad when we see that the success rate is so dramatically different. Fortunately, the treatment protocol what we follow is the same what they do. The chemotherapy drugs, the treatment what is being given here in India, or for that reason in low income countries, majority of the drugs are similar. So there is no difference in the treatment protocol in toto. But what makes this difference? What is the reason for having this stark difference is supportive care. And also, of course, there are some other features. One of the most common cause for having this impact is supportive care, in that the top priority is nutrition. Okay? So malnutrition is one of the most common cause for having this kind of difference, even though you try to give the same treatment for the child who is in this scenario, in this low and middle income countries, they may not be able to tolerate it because their nutrition is not so good. They won't tolerate this chemotherapy at all, right? And then your success will definitely not be there, right? So you have a role to play, a very important and vital role to play to improve the success rate from here to here. So we need to jump. And it's not possible with us. It's not possible only by us. It's only possible when we work together. It is not a complementary, it is a part of treatment. This childhood cancer can be divided into 2 categories, liquid cancers and solid cancers. Liquid cancers are leukemias, lymphomas. Solid cancers are organ-wise, we can tell the brain cancers, that is medulloblastoma. Abdomen, we have neuroblastoma, Wilms tumor. In liver, we have hepatoblastomas. In bone, we have osteosarcoma, Ewing sarcoma. Muscle, rhabdomyosarcoma, INRSTS, and eye, retinoblastomas. So these are some of the common childhood cancers what you encounter when you practice, right? When you see in the clinically, you see this kind of diseases. So the treatment modalities which have been used in childhood cancer are mainly 4. They are chemotherapy, surgery, radiation therapy, and bone marrow transplantation. Any doubt in this? So we use chemotherapy. We can probably say that chemotherapy, immunotherapy, targeted therapy are all one kind of medical treatment. Surgery is something where the mass need to be removed, so there will be surgery. Radiation therapy, we'll try to ablate the cancer cells by giving radiation. And also bone marrow transplantation is a special therapy which is used to treat the disease which is refractory. So why is this done? Why is this class taken? To tell that why you have only stressed on ICU patients is because when a child stuck with this critical illness, can be because of any reasons. When the child is stuck with this critical illness, there are so many things that goes into his body. Okay, so his metabolism gets disturbed, right? And the child will have excessive lipolysis. There will be glycolysis, excessive utilization of glucose, and also there is breakdown of the muscle, so rhabdomyolysis. So glycolysis, rhabdomyolysis, lipolysis, everything goes haywire, and then that leads to lot of issues. So you need to plan your diet in such a way, right, that it compensates this catabolic state also. So it's a stressful condition. A child in ward, a child in ICU is definitely different, right? That is why this class is completely focused on children who are in ICUs, correct? So what are the indications why these children go into ICU? It can be divided into two categories. One, a child with the disease presenting to you in an emergency situation wherein which we take the patient directly to ICU. And second one is, once you start the treatment, he or she will develop a complication because of your treatment that makes the child to go to ICU, right? So either the disease itself is making the patient go to ICU or your treatment is making the child go to ICU, okay? So oncological emergencies can be divided into four categories. That is, emergencies because of the mass lesions, because of hematologic or metabolic reasons, immunosuppression and pain crisis, okay? So let us see what are oncological emergencies because of the mass lesions. So they are mediastinal mass, spinal cord compression and raised intracranial pressures, okay? So coming to the next, that is tumor lysis syndrome. So what is tumor lysis syndrome? To understand this, there are two things which are there in this. There is a tumor and that is lysing, okay? So because of tumor which is getting lysed, there is a condition which is resulting called as tumor lysis syndrome. So these cells which are constantly forming and constantly dying, so they will be very fragile cells. These cancer cells will be very fragile cells. And then they will not be having any work. They will just multiply and then they die. So when they die, they will leave all chemicals which are there in the cells will come out into the plasma, right? So all those chemicals will create a lot of issues to the body. So it can happen on its own even before treatment, but it happens most of the times when you start treatment. When the patient comes to you and you start treatment, the child suddenly responds to that and tumor cells die immediately. So when they die immediately, they will liberate a lot of chemicals. And the body is not made to remove that many chemical at that time. So then it starts accumulating in the body. So that will result in hyperkalemia. Potassium will go high. Hyperuricemia. Uric acid will go high. Hyperphosphatemia. Phosphorus also will go high. Hypocalcemia. Calcium will go low. Okay. So you need to plan your diet accordingly. So that is why we always instruct a newly diagnosed child not to have high potassium containing liquids or diet, that is fruits, right? So we avoid it. Why do you avoid? Because of this. Got it? It is all because of the high rate of cell turnover and death. So this is also the same that explains. Here is a tumor cell which lies that causes high potassium, high uric acid, high phosphorus. This high phosphorus will bind to the calcium which is there in the body and depletes it. Okay? It is not that calcium is going somewhere. It is just binding to the phosphorus. So calcium goes low and it can also cause calcium phosphate crystals in the kidney and kidney can get damaged. Lactate and other metabolites also gets deranged. So when it happens, usually when you start cytotoxic therapy, or it can also happen spontaneously. So you should be geared about this condition. Whenever you see that a new child is there in your ward and you are going to address them, you should be aware of that these are the situations which can happen. There are so many disturbances in the electrolytes. You should be aware of that when you advise your diet. So what all things can happen in laboratory findings? You see that uric acid can go very high, that is more than 8, potassium more than 6, phosphorus more than 10, and calcium less than 8, ionized calcium less than 0.5. There will be elevated LDS, WBC, creatinine, blood urea nitrogen. So these are some of the laboratory findings which are usually seen in tumor lysis syndrome. And the clinical features, they usually will have nausea, vomiting, diarrhea, muscle cramps, numbness and tingling, irregular heartbeat, agitation, lethargy, seizures, hypertension, flank pain, hematuria, renal stones, renal failure. So these are some of the clinical symptoms with which they will be presenting with. So this is a condition where they will be regularly monitored and need to be tidying off. Probably it usually lasts for about 3-4 days, 4-5 days. It need to be taken in a meticulous way. So how do you manage it? We give a lot of fluids, and especially the fluids will be potassium free, right? So it must be potassium free. We are not going to give any potassium in the fluids, neither fluids nor orally. Orally is your work and our work is IV. That IV we don't give any potassium. But hydration is very important, that it flushes all the chemicals through the kidney. Kidney is the only way that it removes all the chemicals which are accumulated. So hyperuricemia, for hyperuricemia we give allopurinol or raspberry case. For hyperkalemia we need to get it out, so we put lot of diuretics. This is to put the potassium out of the body. Kyaxylate is to decrease the absorption. We put that into the gut so that even if you are eating any potassium, it will not be getting absorbed. So it gets absorbed to the drug and then it goes out. So glucose, insulin, salbutamol nebulization, IV calcium gluconate, all three are to temporarily shift the potassium from the extracellular compartment into intracellular compartment so that potassium gets low. So it is not going to remove the potassium from the body. And last one is dialysis. If nothing is working, then this is the last resort where we try to remove the potassium out of the body. So hyperphosphatemia is again, if phosphorus is high, then you put some drug which will absorb the phosphorus in the gut so that excessive absorption of phosphorus doesn't happen, right? So that we use sevelamer, right? And if it goes beyond, then of course dialysis will come into picture. Hypocalcemia is not going to be treated unless it is symptomatic. If the child is having any symptoms because of calcium being on the lower side, then we treat. If not, it is not supposed to be treated. Why we don't treat? Because the child is not that deficient in calcium. It is only the calcium is associated with, it is binding with phosphorus, which is high unnecessarily. Once you remove the phosphorus, that calcium will come back, right? You are not supposed to treat it. But if there is any symptoms which are arising because of that, you need to treat it. So dialysis if the kidney goes wrong.